Hey, welcome back. I changed for you. I hope we look all right this afternoon. I hope you had a nice potty break or got some coffee for the remaining 2 webinars in our series on chronic care models. I'm Dr. Eric Vanderlip. I'm a family physician and psychiatrist at the University of Oklahoma School of Community Medicine, and I'm in the departments of medical informatics, psychiatry, and family medicine. This is webinar number 6 in our series of 7 for chronic care models. And today we'll be discussing how to figure out how to engage your team and fundamentally prevent burnout. We'll be reviewing some of the data that shows us that burnout, retention, and attraction and recruitment of key staff are crucial to our integrated care models. And then we'll be talking about the theory of burnout and why it contributes to so much problems in our implementation efforts. Many of you scattered across the state of Oklahoma are intimately familiar with our workforce challenges and retaining staff problems that we have in our community behavioral health systems. So I'm hopeful that this webinar in particular can offer some guidance on how these models can help steal you from burnout. Let's recap just briefly. We talked first about the world of integrated care and the fact that integrated care is the general blending of behavioral health services and primary care services. Behavioral health encompassing both substance abuse services and mental health services combined into the umbrella of behavioral health. Integrated care is putting both of these together. It's a two-way street. You have systems and interventions that bring behavioral health services to primary care settings, and primary care services, other interventions that bring primary care services and wellness and health to primarily behavioral health settings, because these two systems have been fundamentally separated since the dawn of time. There are better and worse evidence-based integrated care models, and what we've talked about in several of the beginning webinars is the fact that Americans and the rest of the world are living and dying from chronic illnesses. We have to redesign our healthcare system fundamentally to manage chronic illnesses and engage people in their care. We talked about the collaborative care model as a model that approximates the chronic care model and is an evidence-based approach to blend behavioral health services into primary care settings, and we reviewed that. And then we talked about adapting that model into community-based settings and the importance of using a data or using measurement-based outcomes and tracking them for a population of patients in a tool known as a registry or a mechanism called a registry. All these things are essential aspects of chronic care, and they're part of where our healthcare system is going. Giving these tools and working within these systems allow us as a team and us as a system to protect people from burnout and keep people retained longer in our services. And hopefully we'll be talking about that today as part of this webinar, which is called Engaging and Sustaining the Care Team. Super big point. I have no disclosures. I'm not broke, but anyway. Okay, turns out this is the new integrated care team. They're not all white males, although it looks as if they're all good-looking white males. I mean to say we want A+ teams out there working for us, and I want to treat our team as if they are rock stars, because you all are rock stars in the teams that you work on. In fact, you could all come in to work every day to slow motion music and some anthem playing in the background. That would probably make our lives a lot better. Your team might also look like this, and that's all right too. Sometimes we have to make the best of what we've got and keep them engaged and give them the skill sets necessary to feel like they can make a difference. So regardless of what your team may look like now or what it looks or what you'd like it to look like, I think that these principles apply to everybody. So I have to tell you a personal story about my experience in integrated care. And if any of you are familiar with Despair.com, I don't own any stock in this group, but I think they have the funniest posters ever. This one says mistakes, and then it's this sinking ship, and it says it could be that the purpose of your life is to only serve as a warning to others. I think that's part of my role here. I have to tell you a story. I worked at this facility called Navos, which is a wonderful community behavioral health facility near Seattle, Washington. And there I was a family physician working in an integrated care program, bringing primary care services to a community behavioral health system. Some of you might be familiar with SAMHSA's PBHCI grant program, which was Primary Behavioral Health Care Integration Grant Program. This community mental health center had received a grant to do that kind of work, and I was a primary care physician working in this system. They advertise these services. This is their website as of a year or two ago, showing the integration of behavioral health and primary care is a big deal for them, and they were offering these services to their clientele who were coming into the mental health center. They said, by integrating care, we can improve prevention, early detection, and treatment of serious health issues, including chronic diseases. And that is absolutely true. And we all wanted to provide that care. And we were all at the beginning and had a lot to learn about what it takes to integrate services. This was the Community Mental Health Center. It's a beautiful, brand new facility designed from the ground up with the notion of integration in mind. In fact, they'd even consulted persons in my chop shop at the University of Washington, where I was then, about how to build out their floor plans to design their clinic. And this is an example of this, and I'll show you this floor plan. All these offices were their case management offices and psychiatry consultation offices. This was the primary care clinic with exam rooms and an open floor plan. This floor, and this over here was a shared waiting area for both behavioral health and primary care. They thought critically about what would be necessary to integrate services on a systematic level when they built and constructed this outpatient community behavioral health center. And we had the luxury of moving into this place. What an opportunity. And here's a picture of the primary care clinic. We had procedures. We could do all kinds of stuff in there. We had labs on site. Fantastic. Shared waiting area. The problem is we were all running around like chickens with our heads cut off. And even though the case managers walked by the clinic every day and we could see them, we rarely had enough time to sit down and coordinate and collaborate. We rarely had enough time to think about what we were doing and the outcomes we were providing. Partly because our primary care system was still dependent upon getting paid for seeing patients one after another. And we weren't really in charge of making sure that their diabetes was necessarily getting better. So because of that, we had a care manager, a nurse, who was very gifted. She was fantastic. But she often was scattered. She had to put out flame after flame and was doing a lot of social work and case management things. And we really weren't using her to the best of our abilities. And it was frustrating. It was frustrating for her and it was frustrating for us because we knew that people weren't well, but we didn't really have the capacity to follow up with them and all work together. And we didn't really have the capacity to see how things might be changing as a result of our efforts. When you have this vacuum of services, chaos reigns. And all you get is a chaotic system. And that's what we were in. We kind of replicated this co-located approach to care, which is where you put a primary care clinic just in a community behavioral health center. And you don't actually shake up the system or make them or force them or give them the capacity to collaborate across lines. Even though that could have happened a little more than regular, it just was hard to do because time is precious and our time was spent actually seeing patients, not collaborating. And when you have a vacuum, when you have chaos, whatever is the most urgent thing that's going on has a tendency to capture your attention. It's as if we're in a room and the house is on fire. And the sprinkler system to turn the water on in the house and turn the sprinklers on is just outside of the room. If the fire is encroaching on us, it's impossible to get outside of that room. We have to put the flames out everywhere. And all we really need to do is just start from the outside in and turn the water on, and that's going to turn the fire off. But if we start inside the house, it's really hard to get out, and we're just putting out flames left and right. This is urgency, and this is something, there's actually a term for this. It's tyranny of the urgent. And this happens time and time again in clinical medicine. It happens to you, it happens to me, it happens all the time. And when we don't have a solid system in place, focused on that allows us to focus on certain things, we digress into this chaos and we just want to put out flames. And that's exactly what happened to our nurse care manager. It's what happens to me in primary care when we're just trying to take care of whatever is most urgent at that time. And it feels like we can never quite get ahead of the game and really focus on people's health and well-being. The way you battle tyranny of the urgent is you form a system. And the system allows you to focus on certain things. And if you focus on certain things, then you can avoid, bake into your day-to-day life specific focus on outcomes. And if you do that, then you can avoid the chaos. The chaos will always find its way of getting to you. But you can avoid the chaos and focus on the things that are most important to make sure people are getting healthier. So when we talk about these systems and we talk about collaborative care models and chronic care models, there are simple and complex interventions. A collaborative care model for general behavioral health to primary care integration is a complex intervention. There's lots of moving parts, and it requires a pretty big upheaval in the culture and the practices and the day-to-day workflows of people. This is a quote from the Cochrane Review looking at collaborative care as an evidence-based intervention for bringing primary or behavioral health services to primary care settings, calling it a complex intervention because it's got multiple moving parts. And when we think about the total world of integrated care being primary care to behavioral health services and behavioral health services to primary care, the bulk of behavioral health occurs here, which is Archer and Gilbody's, that version of integrated care that they reviewed in that Cochrane Review, where we're bringing behavioral health services to primary care. And that alone is a complex intervention. Honestly, bringing primary care services to behavioral health settings like we tried to do up in Seattle and what you're trying to do with the health homes is an even more complicated intervention. Up on the top, where there's relatively fewer people, but they cost a lot more, the intervention is more complex. There's more moving parts. The teams need to be bigger, and the caseload sizes probably need to be smaller than in less complex interventions where the overall engagement capacity of the population is better. Here in primary care populations that maybe aren't FQHCs, but normal employed individuals who we can teach better, don't need the systematic engagement that the more complex interventions do, where we have to have more team members who have more skill sets to engage people and overcome their multiple barriers to getting healthier. The reason I'm telling you all of this is because when we're avoiding tyranny of the urgent, we have to create a system. What you're creating in community behavioral health in terms of bringing primary care services to behavioral health settings is a very complex intervention. When we look at those SAMHSA PBHCI grants, like the NAVOS one that I was doing, we know through the research and the study of this that one of the biggest barriers, both at baseline and a year follow-up of these programs that are implementing primary care and community mental health settings, is staff recruitment and retention. Staff recruitment and retention is the biggest barrier for all of these programs. And it was a barrier in Seattle, it's a barrier in San Francisco, it's a barrier in New York, and it's a barrier in Oklahoma. Here, we feel like our workforce is much more depleted, and arguably, I think that it probably is, but people in San Francisco and New York also complain about access to good quality staff and good recruitment. So we've got to do something about our system that keeps people in longer, the people that we do have. What do we do? So this is a study from Scharf et al. Psychiatric Services, 2013, just showing that one of the largest barriers was recruitment and staff time. The other biggest barrier, data management. EHRs, registry products, and outcomes. So if we're going to take a system, I think burnout, retention is related to burnout. And if we're going to create a system to overcome tyranny of the urgent and keep people retained so that they don't feel scattered like they're chickens with their heads cut off running around, we need to not do this. We need to not try to pound a square peg into a round hole. I think that is what is so frustrating. You can imagine this is a frustrating process. What's frustrating about pounding a square peg into a round hole? The fact that you're working a lot, you have to get something done which fundamentally doesn't make sense, and you know that it's an impossible task and you're not getting anywhere and you're not getting any outcomes. That is burnout to me. And taking our staff and putting them square pegs into round holes is challenging and can lead to burnout. And there's a skill set that's required for burnout. And sometimes when we bring primary care services to behavioral health settings, it's useful to know what works well for primary care physicians that have been put in behavioral health settings in the past. They need to be people. Primary care physicians are not generally medically trained. They're not real savvy with the lingo and the culture and the world of behavioral health. But they also have a deep passion for caring for underserved populations, as do you. They have a slightly different approach, though, this medical approach. And sometimes they can be that square peg in a round hole, and that can be frustrating and lead to burnout and turnover in the primary care side of things. You need to have a PCP that is flexible with a sense of humor, adapts well to behavioral health environments, likes working with patients with mental illnesses. They need to have compassion and passion. They need to enjoy being part of a team, which is something we're more familiar with, relatively speaking, than in general medical settings. And they've got to want to make a difference, and they've got to be fine with using data to drive their outcomes. When PCPs, primary care physicians, or the general medical staff that we bring into our settings and try to put in our systems don't kind of align with some of these principles, it can lead to frustration, and then the systems can fall apart. We know that from prior implementation problems or studies. And because of that, SAMHSA at their Center for Integrated Health Solutions has a make your own primary care physician guide. So those of you who are following along, playing the home game here, you can look at the Center for Integrated Health Solutions. There's a link on the slide, and you can download the guide. It's got modules, 30 slides. It talks about the world of behavioral health and the culture of recovery and functionality, et cetera. And so there is some support out there in curricula for you if you have PCPs that are struggling to really grasp the culture of your community mental health center. Some of this stuff might be useful. So part of recruitment is to find the right people. So we know that recruitment and retention are two major barriers to workforce and operationalizing these primary care into behavioral health systems. And if we have a better system, we have less burnout. And we're talking right now about engaging your staff and keeping them engaged. That's what this whole webinar is about. So on the recruitment angle, the most important thing, like this slide shows us, is to find the right PCP, the right person with the right mentality, the right mantra, and then train them up. And cross-train them and give them the skill set necessary, the shoes necessary to do the work, but they've got to be the right person with the right passion and the right warm, empathic ability to work well in a team. It's really hard to get that. That can be trained, but it's really hard to get. If you find the right person, then you can train them up with the right skill set. And that's what we've found in some of these implementations. So we know that also in large-scale integrated care efforts, ongoing booster shots or recruitment and then retention of these staff is very important. And so as you're designing your program and you're thinking that you want to avoid tyranny of the urgent, you want to invest in a system, and you want to get staff that you can recruit and retain to engage them, you're going to want to have an initial bolus of training then, because you're going to want to find the right people, the right warm, empathic people to get on board, and then you're going to have an initial bolus in training to get them more accustomed to things and all on the same page around medical approaches to diabetes, for instance. And then you're going to want to give them just basal boosters over time, booster shots of little training sessions to remind them what those principles are and remind them what the basics are. If we move past recruitment, that's how we do recruitment. You get people and then you train them up, and when we talk about training, you give them this initial booster, and then you give them an initial bolus of education and then booster shots following up. If we talk then about retention, how do we keep people retained? That's by avoiding burnout. And I want to go back to burnout now. So how do we avoid burnout? Well, I think, so retention is in part burnout. Here's my equation. Burnout equals a combination of not being able to witness change and then not having an ability to change things so that you can see the change that you're doing. So change the way that you're working or something like that. So therefore, retention equals actual ability to produce change, meaningful change, and change up your system to guarantee that you'll get better results. So if we were then to dissect that, or think about this functional system that avoids this tyranny of the urgent and also prevents burnout for us, a functional system provides optimization of the ability of an individual person in it to witness change in the people that they're doing. So to both work well, like they'd like to work, and then see the changes in the population that they're trying to affect. So a functional system allows us to avoid tyranny of the urgent and retain our staff better because there's less burnout, because a functional system will let them see their change and work like they'd like to work. Have I said that 5 different times now? I had to convince myself of that, sorry. So what does that then look like? So if we have an optimization of ability, then that means people working at the top of their licenses. And then if we talk about witness change, for them to be able to actually see changes in the work that they're doing in their abilities, that's measurement-based outcomes and use of a registry. So I think that actually these collaborative care models are natural antidotes to burnout, which is a natural antidote to retention, which is a natural barrier to implementation of complex systems, which is what you're trying to do with health homes. That's why we're having this discussion. So pounding away at these square pegs into round holes is very frustrating and leads to burnout. Most of healthcare these days, when we talk about healthcare reform and primary care and everything else, and I think I've shown this slide, I think I showed this slide before. Maybe, maybe not. Most of healthcare is about trying to change the way we do things, change our system approach to managing chronic illnesses. The way we invest in a new system to avoid this running around like chickens with our heads cut off and tyranny of the urgent and chaos, which burns people out because they feel like they're never getting anywhere and don't see anything changing, is to invest in a system that allows us to see the change and work at the top of our licenses, or the top of our abilities. And that's more on burnout. This is what I feel when I think of burnout too. I think of trying to squeeze this big ship through this tight little canal. It's so frustrating, it's futile, and you spin your wheels. This is burnout. When we give people the metrics and they can see how their work is actually changing things, or they can readjust their approaches because they're all working at the top of their license, then that helps prevent burnout. By the way, also sharing the load with team members and not feeling solely responsible for making things change can be very effective and can allow people to commiserate. A lot of you know this already in the teams that you work on in community behavioral health. That's actually the bulk of this webinar. So I just want to reiterate that we're talking about we're talking about principles of the chronic care model, and we're talking about setting up these teams, and how do you feed and water your team. You have to give them the skill set necessary to affect change in the population. So find the right people that are warm, empathic, can work with others, give them an initial bolus, give them boosters in terms of skills so that they can have the right skill sets, and then you retain them by feeding back data to let them see how their outcomes, how their work and that skill set is making a difference in the populations they're taking care of.